So I am a surgeon specialized in breast care, benign and malignant disease. I did a fellowship in that as well as plastic surgery and general surgery, but breast is what I do, and it's been what I've been doing for approximately 10 years now. So we are going to make this interactive. I want you to feel free to stop me if you need me to stop. I want you to feel free to comment if you think there is something that you really think everybody needs to know, because what the goal of this is to take something from this that you can use in your practical life. It's not just for us to talk to you or talk at you and give you nothing that you can walk away from to actually use in your practical life. So I am not going to give you a cancer chat, because this is not about cancer. This is about wellness. And it's about how do we keep ourselves healthy, how do we keep ourselves well, and what things can we put into place to make sure we stay that way, okay? Because all of you are absolutely stunningly wonderful looking women. None of you look like you're about to fall over tomorrow. You look healthy, you are mobile, and you are active, and that is the goal of keeping you here. So when we think about why do we do this? Why do we think about breast wellness? Because many years ago, some of you may remember, before 1976, before mammography became standard of care, for many women who got a breast cancer diagnosis, it was a death sentence. We did not have tools to screen appropriately. We did not have great tools to treat with quality of life thoughts. So after 1976, with the advent of mammography and the advent of some recommendations for screenings, we realized that we were finding breast cancers at smaller and smaller sizes, lower and lower stages, and survival rates went up. So today, and in the last, 10 years or so, when we looked at some of the factors that increase breast cancer risk, and we really started looking at some things like hormone replacement therapy. Women love their hormones. And we looked at some things that we could put into place. We have seen that the incidence of the breast cancers that can kill you, which are the invasive breast cancers, have actually been going down. And survival rates have been going up. 2013, 2014, about 260,000 women in the United States will be diagnosed with an invasive breast cancer, and those are the type that can spread to go to other areas of your body. But about 65,000 women are going to be diagnosed with non-invasive breast cancers, and those are the cancers that do not have the ability to spread to other areas of your body. Now, because we don't have a molecular tool that can tell us which one of those non-invasive cancers could turn into a big, bad, nasty invasive cancer, we treat those, and we recommend treating all of them. So you're going to see, and especially recently in the media, they've been talking about ductal carcinoma in situ, or this non-invasive cancer. It's not a cancer, it is a cancer. Don't be fooled, okay? Left alone, it will continue to grow. It does not care about form or function of your body, and 40 to 60% of them convert to invasive cancers over time. That's why we treat them. When science catches up and can tell us which ones are going to turn into something else, we'll be able to have better tools to tell patients this is a cancer that does not need to be treated because it's not going to change, but this one does. We don't have that yet. So don't be fooled by somebody who says, girl, that ain't no cancer, that's non-invasive. Nothing gonna happen with that. Talk to your doctors, talk to the specialists, get as much information as you can to make the care choices that work best for you. Okay? So when we think about what do we do to reduce our risk of getting cancers, we think early detection. You partner with your doctor, and you develop a breast wellness plan as part of a total wellness plan. When we think partnering with your doctor, you make sure you have your clinical breast examinations by your doctor or your nurse practitioner or your PA at least once a year if you're a woman of average breast cancer risk. If you are a woman with elevated breast cancer risk for a number of reasons, you would have that examination twice a year instead of once a year. We ask that you have an open, honest conversation with your doctors, nurses, or healthcare providers about your family history and your personal history, because there are elements of your family history and your personal history that may push you a little bit more towards that high-risk category. And we ask that you talk with your families even about it, because for a long time, with many different cancer diagnoses, we had this culture of silence. If you talked about it, you were going to talk it up, and we don't want to talk about that, and oh my God, my Aunt Sally died of cancer. You know, have those conversations because your family history is important in helping you determine what is going to be best for you for screening and surveillance. We recommend that you perform self-examinations. Okay? Now, I'm going to be perfectly honest with you. There are no studies that show that breast self-examination improves breast cancer survival. But we encourage it anyway. Because in the world that we live in, there are many women and men out there, when the economy gets bad and we start losing jobs or we get to retirement age and our incomes become fixed, one of the first things that we let go of is health insurance. And in families and households where money becomes tight and we can't quite afford all the health insurance that we need, the person who gets the medical care is the person who has the opportunity to perhaps work, and usually that's the men. And then children and grandchildren take precedence. So the last person in line is the woman. So if you're not able to go see a doctor because it's not something that you can afford to do, and you're not getting mammograms because those are coming out of pocket and you can't find a program that can pay for it for you, if you're not doing self-examinations, how are you going to find those lumps? And we've known scientifically, women who do self-examinations regularly find lumps when they're smaller. And the smaller the cancer is, the less likely they're going to be to spread to lymph nodes, and the lower the stages and the higher the survival. So they're not harmful to do. They're free, okay? If you have a partner and you still have intimacy, you can have partner participation to help it get done. So I do recommend, and we do nationally recommend, self-examinations. If you can do them monthly, great. If you can do them every other month, I'm still happy. If you can do them once every 3 months, quarterly, I am still happy. Okay? Because those are still regular self-exams as long as you know what is normal for you. And then, as Dr. Flukinger said, for women over the age of 40, we do still recommend mammograms annually. If you have elevated risk or family history that indicates that mammograms should start before the age of 40, that is something we need to talk with your doctors, and they will help you determine what that protocol is for you. We do not have an end date. As long as you are vibrant and active and mobile, keep on getting them. Okay? If you have quality of life, you keep getting them until quality of life is gone. So we don't have a cutoff date at this point in time. Now, there are women that I see who are in their late 80s and 90s who say, I'm just not doing it anymore. I don't fight with them about it. We talk about self-examinations. They still get their clinical exams. I don't fight with them about it. I still encourage it, but I'm not going to, come on, really? My grandmother died when she was 91. She was almost 92. I could never get my own grandmother to get a mammogram, and I'm a breast surgeon. I understand, okay? But I still encourage, if you have an active, healthy lifestyle, if you are getting out there, if you are still getting in that car and driving, you can still go get a mammogram, okay? If you are still getting in the car and being driven to a nice lunch, you can get a mammogram. So, if you're getting out, I'd love it for it to be done. Okay? And then we think about the things that you can control for your wellness, okay? So when we think about those things, people are like, well, what's my risk? Okay, so let's talk a little bit about that. We're going to talk about the things that you can't do anything about. And my rule is, if you can't do anything about it, don't worry about it. You can't change it. Do not worry about it. Okay? Things that we cannot change. The number one risk factor for developing a breast cancer is having breast, being female. You can't do anything about it. Even if you go get surgery, your DNA is still female. Okay? You can't do anything about it. Even if that young man decides that he's going to be a young lady, he is male genetically. All right? So we don't worry about that. Age. The older that we get, breast cancers are more common. After the age of 45, breast cancers are actually have an increased incidence in Caucasian women as compared to women of other racial and ethnic backgrounds. Can you change your ethnicity? No. I don't care how much Botox we get. I don't care how many lifts, peels, and tucks. You can't stop the hands of time. So we don't worry about gender. We don't worry about age. We don't worry about ethnicity. There are people in my family that I do not talk to because they get on my nerves. But I can't change my family history. Okay? If you're aware of it, You know what it is, but you can't change it. So you don't worry about it. Things that you also can't do much about, the age at which you started having menstrual cycles. Women who start having menstrual cycles very early actually may have an elevated risk because we consider them to have prolonged estrogen exposure. Short of surgical intervention, you cannot change your age at which you stop having menstrual cycles, menopause. Okay? Again, short of surgical intervention, and I don't know very many women who are asking for surgical menopause. Okay, we don't want it when it comes on its own. Okay, so I don't know too many women who are asking for it. So those are things that we can't change. Women who go through menopause late, meaning after the age of 55. Again, prolonged estrogen exposure actually elevates breast cancer risk. And that's your own estrogen. That's not some extra coming from somewhere else. Can you do anything about those things? No, you don't worry about them because they're not things you can impact. Other things that we have a little bit of impact on.
Well, what's considered early menstrual cycle? You say 55?
Before the age of 11.
Oh, okay.
Before the age of 11. So think, if you've had periods starting at 9 and you don't go through menopause until you're 60, that's a long period of estrogen exposure. Yes, ma'am.
So it takes a few years for some people to go through menopause.
Yeah.
If you start at age 55 and finish at 58, or start at age 52, I mean, so what is the...
The definition of menopause, and this is in my talk actually, is absence of menses for a year.
Okay.
So it's not the perimenopausal transition, it's the lack of a period for a year.
Does that make more sense?
Mm-hmm.
Okay. It was something. It was something. It was good. It'll come to me. Prolonged estrogen. Can't do anything about it. Childbearing. Okay. Women who never have children have unopposed estrogen exposure. So being what we call nulliparous or never having had children gives a slight bump in risk. That's not something many women can control. Having children after the age of 25. We call that late childbearing. Although it's not really late, okay? That is not really late. But in the body's talk, it is a little bit late. But fascinatingly enough, which is really, really interesting, we have different kinds of breast cancers, okay? We have some breast cancers that develop in response to estrogen. We call those hormone receptor positive cancers. They grow in response to the presence of estrogen. But we have some nasty breast cancers that are what we call triple negative. They don't respond to hormones at all. They just grow because they grow. And interestingly enough, the triple negative cancers are actually at increased risk in women who have babies younger and have more babies. We don't know why. I know. We have no idea. Fascinating. It's something that we need to study. We have no idea why it happens. So again, are these things we can control? No. Yes, ma'am.
What does the role of birth control pills play in terms of unopposed estrogen? So does that, if a woman takes birth control pills, is that considered like...
Well, for birth control pills, and these are one of the factors that we can control, birth control pills actually have a very, very little relative risk bump up if you have been taking birth control pills for longer than 20 years and you're older than the age of 40. And we talk about it being unopposed, and that's kind of longer than 20 continuous years. So it's a very, very small relative risk bump up. Very, very small. Okay. Yes, ma'am?
What about the rate and longevity of female lactation? Is that
Let's talk about that. Thank you. You guys are so smart. This is the best audience ever. Perfect. No, this is wonderful. I love you. Factors we can control. See how nice segue. So let's talk about the factors we can control. That is one of the factors we can control. Breastfeeding is protective against breast cancer. And we recommend women nurse for longer than 6 months. Okay? So it doesn't mean baby has to be on breast because some children don't have a good latch or some find breastfeeding very uncomfortable. Even if they're pumping for longer than 6 months, breastfeeding is protective. Absolutely. So we want to encourage young women to breastfeed if at all possible. It's healthy for mom. It's healthy for baby. It's always the right temperature, and once milk comes in, it's always readily available. And it's free. Best of all. Okay? Cheap. So we absolutely encourage breastfeeding. That's a factor we can control.
Are we seeing signs of maternal health improving when you spoke earlier?
Yes.
Breast cancer rates coming down, is it because women are lactating and being encouraged?
It's not the only reason, but we do encourage it. And I wouldn't say we see better breast cancer protection just because women are lactating or breastfeeding. We are seeing more mothers who are willing to consider nursing, and Dr. Tabor can speak to that because she has lots of years of experience with just that thing. But it is protective. So let's talk about the big whammies, okay? The big whammies for breast cancer protection. What do we always say every time you go to the doctor? I don't care if you come see me, or Dr. Tabor, or Dr. Ross, or the acupuncturist. Healthy diet and exercise. A healthy, balanced diet, whole grains, lean meats, reducing saturated fats, eating those bright, colorful vegetables and fruits, and having a colorful plate, as we say. You want 4 colors on your plate every meal. You cannot get 4 colors on your plate by eating meat and starch.
That doesn't include food coloring, right?
Not even food coloring. That can be dessert. Food coloring, not including food coloring. So, 4 colors. No, that's so cute. I remember that. So, 4 colors on your plate every meal. And we want the colorful foods to be more than the what we call the neutrals. The neutrals are your browns, your whites, and the creams. You're not going to get the reds and the purples and the blues and the yellows, the bright yellows, from meat alone if it's not a food-colored meat. And if anybody puts a piece of bright yellow meat on my plate, I am not eating it. No, you know what I mean. That you're like, oh, I'm not touching that. But curry's yummy. So, healthy diet combined with regular exercise has been shown to reduce breast cancer risk by 50%. And when we say regular exercise, that is activity. It does not mean you are running a marathon. If you are somebody who is a voracious house cleaner and you are vacuuming and mopping and sweeping and hauling and lifting, if you are a gardener, if you are doing weight bearing, if you're doing Tai Chi, if you're doing yoga, if you're line dancing, if you're hanging curtains and you're working up a sweat, that all counts. And we encourage you to exercise 3 to 5 hours a week, not a day, a week. And that's about ½ hour a day if you can get it in. Walking, dancing, riding, anything, we will take it. Healthy diet and exercise would reduce your risk by 50%. And remember how we talked about that nasty triple-negative breast cancer? Well, we don't have pills that we can reduce the risk of those cancers, but healthy diet and exercise can. So we encourage it. And again, just like breastfeeding, free as far as the exercise part. Okay? Healthy diet, you got to buy groceries unless you are working out there in the garden and you have a farm, which I don't. You know, you got to go to the store. We talk about, when we think about diet, some people wonder, oh, should I do all organics? That is a very personal decision. We have not shown any cancer-specific benefit for breast cancer with using organic products versus non-organic products. And in some communities, organic products can be very expensive. I do ask you to just look at what your diet is. And there are some things where you may get bang for your buck. If you eat apples every single day, all day, perhaps organic apples are better for you. If you eat 1 kiwi a year, who cares if it's an organic kiwi or a non-organic kiwi? Some people who eat a lot of poultry or chicken may do better with grass-fed, farm-raised than factory-raised. So those are really, really personal choices. I encourage you to talk with your nutritionists and your dietitians and your primary care and look. Yes, ma'am?
I was just going to say that the cumulative effects are really not proven. You know, whenever possible, the organic is best. You know.
Again, like I'm saying, personal choice. Personal choice is what your budget will allow, what your community and lifestyle will allow. You know, organic or non-organic, we know healthy diet, even if it's not organic, fruits and veggies are beneficial. We want to encourage you to get as much of your natural vitamins and minerals from your food sources. We would. But there are some that you're going to bump up a little bit, and you talk with your doctors about your vitamin Ds and your vitamin Cs and your vitamin A's, okay? And you have those conversations just to make sure you're not living in deficiencies. Okay? So the biggest bang for your buck, healthy diet and exercise, okay? The second biggest bang for your buck, oh God, postmenopausal obesity. So what we say, BMI over 30, after you've gone through menopause, especially if we kind of collect it here, which we tend to once things start changing, that increases breast cancer risk. After menopause, either surgical or physical, we do still create estrogen, and we actually produce estrogen in our peripheral fat, in our adrenal glands over our kidneys, and a little bit in our liver. So the more peripheral fat that we have after menopause, the more postmenopausal estrogen we do create. And that's where that link comes from. So we really want to work. The literature really gives us some really, I think, stringent recommendations. They say, if you gain more than 20 pounds after the age of 18, that's a problem. That's ridiculous, okay? Ridiculous. In the modern era, when we look at current 18-year-olds today, I think that's legitimate because we do have a problem with adolescent and teenage overweight and obesity. Okay? But I am positive, beyond a shadow of a doubt, when every woman in this room was 18, she probably was about this big around, okay? Even if they had children already, because years ago, we were much more physically active. We had PE. We were outside. We were not sitting in the house in front of the television or video. So there was much more physical activity going on in your world. So most of us were very, very tiny at 18. And many people were actually a little bit underweight at 18 many years ago. So again, I say look at that BMI, height-weight balance. You want it to be under 30. Because it may be very difficult to maintain a 20-pound weight limit from 18 until you die. I know I didn't do it, so I don't expect you to do it. But we want you to maintain that BMI under 30. That has been shown to reduce breast cancer risk. Okay. Then we think about other things that we can avoid. Smoking. Smoking's bad, period. It increases not only breast cancer risk, but lung cancer risk, colon cancer risk, the risk of heart disease, the risk of stroke. So smoking is bad. And if we can support our patients in stopping smoking, we want to. Okay? Alcohol consumption. 10 grams or less a day. Glass of wine, 8 ounces or less, preferably 4. Okay? All alcohol is actually considered equal. Beer versus liquor versus wine. Okay, so we say we want a life of moderation. When we first started talking about we'd like patients to reduce their alcohol consumption to 1 drink a day or less, one of my patients actually said to me, so yeah, I can still have my 40 ounces of beer because it came in 1 container. No, we can't have the whole bottle of wine. We can't have the big bottle of no, not the whole picture of margaritas. No, okay. We say 10 grams a day. And on average, that's about 1 drink. The other thing that I want you to remember, binge drinking, which none of you do, okay? Binge drinking meaning I don't ever drink, but you know what? Once a month I go out with my girlfriends, and I have, 3 or 4 glasses of wine, and then I'll have, sometimes we'll have a post-drink cocktail, and then I'll have a margarita when we go to... Binge drinking is just as bad as drinking more than 1 to 2 glasses of alcohol daily. So we just kind of have to watch those things. And for me to get you to understand why, I'm going to tell you how it works, because it works 2 ways. Women and men metabolize alcohol differently. We actually have different amounts of the enzyme that breaks down alcohol in our stomachs. Actually have less of that than men do. So more alcohol in women actually makes it to your bloodstream and your liver once it is absorbed from your stomach. So since more alcohol is getting to the liver, one of the things that alcohol does in the liver is it changes our liver enzymes, the enzymes in our liver that help break down chemicals. One of the enzymes that it changes in your liver is the enzyme that controls steroid or hormone production in the liver. So when you drink alcohol and it impacts that enzyme, you actually get elevated estrogen levels. And what did we say? Elevated estrogen increases breast cancer risk. So that's one way it works. But alcohol's sneaky. Works 2 ways. Alcohol also reduces the way that your body absorbs folic acid. Remember how someone, when you get pregnant, your doctors were telling you, take more folic acid, you want to get good neurons, and you want to have good... Folic acid is one of the chemicals that we use in our bodies to help us repair DNA damage in our cells. All that breast cancer cells are cells that have mutated and have DNA damage that can survive to divide. So if we reduce the level of our enzymes that can repair bad DNA, we increase the number of possible cells that can get that damage and turn into cancer cells. So that's why we tell patients not to drink lots of alcohol. You know, it's not because we think you're a bunch of alcoholics. We're not worried about that. It's because there are actually mechanisms where it increases your breast cancer risk. Okay? Family planning. If you can have your children at an age, or if you decide to have kids, that's good. Estrogen and hormone supplementation. I'm not going to be cruel, okay? The general belief for a while was that all estrogen and hormone supplementation was bad because we actually did establish a link between long-term use of postmenopausal hormone supplementation with increased breast cancer risk. And once we stopped routinely giving every postmenopausal woman estrogen, we saw those breast cancer numbers come down. However, we try not to be so cruel now. Use judiciously, meaning women who are going through menopause and have intractable symptoms. They are having hot flashes 24 hours a day. They're not sleeping. They're not eating. They're depressed. They're chronically fatigued. They're miserable, not just because they're having a couple of hot flashes a day, but really are miserable secondary to those changes. Use judiciously to help symptom management for a short period of time. We don't frown on it. My preference is patients to be on estrogen replacement therapy for less than 5 years, preferably less than 2, but I can't determine symptoms. It should be done with a doctor and a plan for cessation once it starts. It breaks my heart when 78-year-old women come into my office and they've been on estrogen replacement therapy since they were 45. And you know they don't want to give it up in their 70s. It breaks my heart, especially when they come in with a breast cancer and they have to give it up. So if it is necessary and needed, fine. If you don't have elevated breast cancer risk, if you don't have a precancerous change in your breast, that will increase your risk. Having an honest conversation with the doctor about what do I need, so the lowest doses that can manage symptoms for the shortest amount of time possible, fine, I'm not going to fight you on that. Yeah. But we can reduce our risk by not using it. So real quick on gene mutation, because we talked a little bit about that. 10% of breast cancers are considered to be hereditary or genetic. They're actually two different things. Hereditary breast cancers is if you have 1 to 2 generations of breast cancer in your family. Okay. Genetically mutated or genetically mediated breast cancers are breast cancers that are occurring because of a specific gene mutation. 90% of breast cancers that occur in this country are what we call sporadic. They just happen just because. And that person is the family history. They don't know of anybody else who had it. So the majority of breast cancers just happen out of the blue. We don't have a reason why. If we did, we could stop it. And right now, we don't have a magical bullet. You know what Dr. Ross was saying about colon cancer? Unfortunately, we can't apply that to breast cancer, and I wish that we could. Colon cancer is almost 100% preventable if we do what we're supposed to do with screening. Breast cancer is not the same way. We have early detection tools. We have things that we can use to reduce our risk, but we don't have a magical bullet that can just stop it from happening in everyone. And if we did, it would be great.
When you said the breast cancer previous family history, if the grandmother had breast cancer, took care of that, then it came back to the bronchioles, then mother had lymphoma. They're in the same area, but that is not, they are different than breast cancer.
Mm-hmm. So, I mean, the grandmother with breast cancer, the cancer that came back in the bronchioles, was it a true lung cancer, or did they think it was her breast cancer recurring? That's where it gets tricky.
Yeah, I don't remember. It's been long enough.
But
I think there was that suspicion, but it was truly
in her lungs. So, yeah, there's a possibility that it was metastatic. We don't know. When we start seeing some things that kind of crop up generation to generation, and cancers that we think of being clustered on the same genes. We think genetic counseling, and it's not just the breast cancer gene. There's a few other ones that are what we call dominant, they're going to pop up. But typically, breast and lymphoma, unless you have a lot more going on in that family, aren't really related. Although, you know, lymphomas we don't think of as local problems. We think of them as whole body problems because our lymphatic system is in the whole body. Breast cancers we think more of as regional problems. So things that about your family history that may increase your suspicion. If we see breast cancers occurring over multiple generations and you can have a linear line, you know, maternal and paternal, both sides of the family count. You get 50% of your genes from your mom, 50% of your genes from your dad. So never ignore dad's family history just because he's a dude. You got 50% of your genes come from your dad. Okay? So we think about multiple generations. We think about women who are very young, but with those genes, it's bimodal. There's going to be an older cluster and a younger cluster. We think about families that have male breast cancers, bilateral breast cancers. It pops up in both breasts at the same time. That's uncommon. Breast and ovarian cancer together, uncommon. For some of the genes, if we see a lot of breast cancer, colon cancer, prostate cancer, my antennas start waving around if there's a lot of it. In some cases, you will see some thyroid cancers. Sometimes lymphoma, but it's a couple of other things that get tucked in there. So there are actually clusters of cancers when we're taking family history, and my patients will look at me like, why do you want to know about all those other cancers? Because it's not just breast cancer that I'm looking for. I'm looking for other things to see, does this patient need to sit down with a genetic counselor to discuss potential testing of some nature? Pretty much all women under 45 who are diagnosed with breast cancer, we recommend genetic testing regardless of their family history. And that nasty triple-negative breast cancer. We are finding more gene mutations with patients who develop those triple-negative breast cancers. So women actually under the age of 65 who develop those nasty triple-negative breast cancers that are very aggressive, we recommend consideration for genetic testing for them as well. Okay. None of those things is required to be treated for a problem or to be screened and surveilled, but there are tools that can be used to increase your awareness for surveillance that you may need. BRCA gene patients, we want them to be screened for their colon cancers. We want them to be screened for ovarian cancers. And we talk about what we can do to reduce risk. Sometimes it may be medicines to reduce risk. Sometimes it may be surgery to reduce risk. But we want you to be well informed so you can make the choices that work best for you. Yes, ma'am?
Other than the risk factors that you've already discussed, is there anything else you're aware of that raises the risk of the HER2 tumors?
No, that's a really good question. So I'm going to just put that in context real quick.
Sure.
When patients are diagnosed with breast cancers, we look for specific markers on the breast cancer cells to help us guide treatments. We look to see, are the cancers responding to estrogen? We look for an estrogen receptor. Are they responding to progesterone, a little progesterone receptors? Those cells grab onto estrogen and progesterone and use themselves to grow. We also look for a special receptor called a HER2 protein. HER2 is a gene in every cell in your body. And in a normal cell, when this cell is brand new, that gene turns itself on to help the cell mature until its final form and then turns itself off. In about 1/3 of breast cancers, that gene will turn itself on, and instead of turning itself off, it leaves itself on. So it becomes overexpressed on the cell surface, and it acts as a little internal motor to push the cells to grow and divide faster. When we determined that HER2 overexpression existed, they actually developed an antibody therapy for patients who have HER2 positive breast cancers that have been shown to improve survival, long-term survival and long-term disease-free survival. So it gives us extra tools to treat those patients, and it has radically changed survivorship in breast cancer, kind of this new development. But there's nothing that you can do to bump that up, turn it on, or turn it off. It's really that cell and whatever those clones are in that breast cancer cell that took over. So there's nothing that you can do to increase the possibility of getting the hormone receptor positive cancer. You can't control that. You can't control it. 2/3 of all breast cancers are going to be hormone receptor positive, what we call the good kind. 1/3 are going to be triple negative. Okay. 1/3 is going to have that HER2 positivity to give us extra tools to use. For those triple negatives, surgery, radiation, chemotherapy. If the tumor is bigger than 6 millimeters, okay, a triple negative breast cancer bigger than 6 millimeters, we will recommend chemotherapy. Those ER/PR positive ones, those kind of good ones, well, we have pills that can block hormones. We have pills that can prevent your body from even making estrogen. We have so many other tools that we can use, and they tend to have better survival long term. There are a lot more individualized recommendations on should those patients get chemotherapy or not. So, you know, breast cancer care has changed radically in the last 10 years because of not only the early detection tools, but we have some really, really good drugs out there that we use now. We call them good drugs. They're still poisons. Nobody with a straight mind wants chemotherapy, okay? But breast cancer survival, the improvements, early detection, chemotherapy. Not surgical techniques. You know, we have lots of surgical techniques, all kinds of wonderful things where your breast may look better after surgery than they did before, okay? Sometimes. But survival has been impacted most. Early detection, find these cancers when they're tiny. Lifestyle measures, reduce the risk of getting it. And medications. Question?
I have a question.
Yes, ma'am.
So you spoke on ERT and people being on it from 30 to 70 years. And then
Hormone replacement therapy?
Yes.
Mm-hmm.
And then you said there's a pill that blocks hormones.
Mm-hmm. Those are actually hormonal therapy in the cancer realm. They're actually not us giving you hormones. It's actually us giving you medications that block hormones. Because remember, I said, even after menopause, we will still make small quantities of estrogen. And those cancer cells that have the little handles on them that can grab that estrogen and use it to grow, they are actually incredibly efficient estrogen scavengers. Even if you're only making a little bit, those breast cancer cells are so efficient that they can get that teeny little bit. So those people who get breast cancers that would grow in response to estrogen, we treat them with medications to prevent cells from getting estrogen. That's different than hormone replacement therapy. Hormone replacement therapy is we are giving you an estrogen analog so that you don't have those menopausal symptoms. That's different, and that's basically we're giving you estrogens. So that's no, I'm not going to do that, okay? Breast surgeons, I don't give hormone replacement therapy. I don't want you to have it. I'm selfish. I keep it all to myself, okay? But you will be talking about hormone replacement therapy with your gynecologist, and your primary care providers, okay? Because these are the doctors. Sometimes if you have a naturopath, there may be naturopathic methods. These are the doctors and practitioners that traditionally discuss hormone replacement therapy with patients, okay? Cancer doctors, we take it away. We are not nice. All the things that make you feel good, we take it away. And we keep it for ourselves, okay? So, and again, part of that discussion that you have when you partner with your healthcare providers is you have to be very, very honest about your family histories and your personal histories. Because it's a terrible feeling if somebody doesn't give you all the history and you end up giving them a therapy that may be harmful to them. That's not fair to your practitioners, and it's not fair to yourselves either. You have to have those honest discussions about, you know what, I'm fine, but my mother and 3 of my sisters had breast cancer, and you know, my brother Joe, he had colon cancer, and one of his daughters had breast cancer at 25. Might not be the best person to give hormone replacement therapy. Maybe a good person to have that genetic counseling session and to get more information before you go down that road. Make sense?
Yeah.
All right.
So if people want to have,